Good morning, everybody. Good morning. This is the Public Services Scrutiny Committee. It's Monday the 20th of April 2026. We have on the agenda today a number of items. First of all, before we get into those, we've got a number of guests. So we've got the committee. I'm going to allow the committee to introduce themselves. We've got Alistair standing in for Tony this morning, and then we've got our guests, and then we've got the cabinet member, and we've got some backbenchers. We've got Tudor, welcome, and then we've also got Jan, who's an old favourite, isn't she, of this committee? I say that
not so old.
Not so old. I mean that in a warm, friendly kind of way. Jan, I do apologise. It's unnecessary, really, isn't it? So my name is Armand Watts. I'm the chair of this committee. I represent Thornwell. To my right, I've got Hazel. How would you describe yourself, Hazel?
Scrutiny.
Chair?
Scrutiny?
Yeah.
No.
You're definitely not the clerk, are you?
No, I'm not.
No, okay.
Please could Penny turn her mic off, just so that the camera's squarely on you.
Isn't this yours? Oh, it's mine, is it?
Yeah, that's fine. Squarely on the chair now. No. Thank you.
Thank you.
Right, introduce yourself, Penny.
Oh. In that case, I'll put it on.
No, it's that one, Penny.
I'm Penny Jones. I'm County Councillor for Raglan, and I'm Vice Chair of this meeting.
Yeah, and then Marion.
Councillor Marion Howells, Ward Member for Llanbarrack and Usk.
Malcolm. Use mic's off, Malcolm.
Malcolm Lane, Board Member for Mardy, a member of this committee.
Steve.
Steve Garrett, I'm the Ward Member for Overmono in Monmouth.
Okay, and then we've got Jill.
Hi, good morning. Ward Member representing people from West End in Caldecott.
And we've got Alistair, who's standing in for Tony. Welcome, Alistair. Thank you for coming along to the committee this morning.
Good to be here, and you've already introduced me, so thank you.
Okay, and then we've got, if you don't mind me just bringing you in, Jan, you were a former member of this committee. Welcome back. If you'd like to introduce yourself.
Well, I'm Jan Butler, as has been said, and I'm the ward member for Goitrevauer.
Okay.
And thank you for letting me join you today.
No, you're very welcome. Tudor, good morning, Tudor.
Yeah, good morning, Board of Dark Crossor. Tudor Thomas, I'm County Councillor for Park Ward.
Okay, and then good morning.
I'm just an observer today.
Yeah, no, it's okay. You're welcome. If you want to ask some questions that later, we'll bring you in. That's absolutely fine. Thanks. And then Emma, good morning. Good morning.
Hi, Borda. Emma Breen, Ward Councillor for Wisham in Monmouth. Thank you for letting me attend today.
Okay, and we've got our guest here. We've got Megan. Yeah, good morning, Megan. If you'd like to introduce yourself.
Hi, I'm Megan Escott. I'm a team leader for the Tenancy and Supported Living Project with Minding Gwent.
Okay, good morning. Thank you for coming along. Have we got any other? Are we missing people already?
They're going to come in at 11.
Okay.
The health board to join
okay.
At 11. So the first part is for Megan.
Okay. We'll go straight into the agenda, though. So we've got apologies for absence. I know that we've got Tony, but we've got a stand-in. Dale's busy working on a chateau in France, renovating that, so he's busy. Have we missed anybody? No, everybody's covered on that, so thank you for that. We've got any declarations of interest?
Yes, Chair. I'd just like to say I'm an independent member of the Narian Bevan Health Board, and I'm also chair of the Mental Health and Learning Disabilities Committee.
Thank you.
Thank you,
Penny. And then we've got Jill. You've got your hand up.
Yes, I'm a psychotherapist and I volunteer for Base Camp in Chepstow.
Well done. Yeah, brilliant. Excellent. And so we're now into...
Sorry, Chair, I've got my hand up just to declare an interest.
I do apologise. Yeah, what's your interest, Alistair?
Thank you. It's simply that I'm an independent member on the board of Digital and Healthcare Wales, which is another strategic health authority.
Okay. That's fine. That's great. Thank you so much. Number 3 on the agenda, public open forum. Well, we haven't got any members of the public, have we? So we'll skip that. Just at that point, if there are any other members of the public out there who are particularly interested in this theme, All you have to do, we have had members of the public make representation at this committee specifically about an issue to do with the Severn Bridge. We are open to listening to members' views, members of the public's views in this committee. So unfortunately we haven't got anybody today, but if you do fancy coming along at a later stage, then by all means, get in contact with us, reach out to us. Number 4 on the agenda.
Jill,
sorry.
Jill's got a hand.
Oh, Jill.
Sorry.
Is it a legacy hand?
Apologies, it is a legacy hand.
Okay, no, sorry.
Sorry.
Okay, so next on the agenda is adult suicide. As some of you know, members have already had in part training on this. We previously had Minding as well, along with an Iron Bevan Health Board. So this is a second interaction with both of those organisations. Some of the members had training about approximately a month ago about adult suicide, so I must say it was excellent training. You've got your mic on there, Penny. We found it very, very helpful. I'm happy in conversation, as this is going to be a very open, casual, informal kind of discussion with both. If anybody wants to bring in some of those themes from that meeting, I think it's probably helpful. However, we'll get straight into it, part 1, to hear from Mind on how mental health services in Monmouthshire are impacting on both positive and negatively on individuals they support. So at this point, I'm going to bring in Megan. Megan, the floor is yours.
Hi, so I believe my manager Jamie sent in a report. It's a letter that we sent in to the Putting Things Right department just after Christmas in January, just because we were seeing quite a few quite major issues that were impacting a lot of our clients, and I think we gave a couple of case studies which are included in the report. Those we had a meeting then on the 27th of March with the local community mental health team. They were very apologetic and kind of took on board kind of the issues that we were raising. One of the main issues that we kind of brought up is the fact that clients are having difficulty contacting the mental health team, and I think I made it very clear that it wasn't a criticism of the people in the mental health team. I really believe that anybody in the mental health team is there because they want to make a difference. We were kind of pointing out that they were fighting a losing battle in the fact that they didn't have the resources to be there for the clients when they needed them. So we had multiple issues of we were ringing the mental health team and it was going to voicemail or just being cut off, which is an experience that clients have had. There was a quite high level of sickness within the mental health team, which means that we're reaching out to specific support workers, specific social workers, CPNs, and getting nothing back because they weren't there, and there was nobody stepping in for them, and a number of just missed opportunities to step in where clients were expressing quite high suicidal behaviours and thoughts. From that meeting, we have received direct contact with some of the higher level members of the community mental health team. So if we ever hit a roadblock with one of our clients, we can email them directly and try and get a result that way. They have actually employed 2 new CPNs in our community mental health team, which is brilliant. It's given a lot more opportunity for them to come out and kind of see our clients, which is fab. And I think they're really working on improving communication within the team and with external agencies. They're quite keen on getting us to come to the award rounds to kind of introduce ourselves and put our names out there, which is a really positive move.
Thank you. Would you I guess sorry to put you on the spot, but the broader issues in the effectively the information that Mine is sending. Do you just want to talk around some of that, particularly around? So I'm not trying to lead you, but I'm just trying to effectively allow you to begin an engagement with members' questions, which are coming after this, is specifically about the resource implications around that and how I think broadly speaking we had a similar conversation last time. I know members last time were particularly concerned and very supportive to what that you do. If you just want to kind of highlight that, and then I'll lead members into some of the questions, if that's okay.
Yeah, do you mean kind of give an overview of things that we do, or kind of the issues that...
Yes, and also then the resource implications. And obviously, you say that you're struggling, they're struggling to communicate. You're probably struggling as well from resources. I don't want to lead you. That may not be the case, but I suspect it might be. If you just want to talk around some of those issues.
Yeah, so we currently, as Mind Monmouthshire, work with around, between our welfare rights and our tenancy supported living and floating support, we work with around 200 people across Monmouthshire. We've made it clear that we only bring certain cases to the view of community mental health team that we feel is a serious risk of life, of hospitalisation or things going into further crisis. So part of the report that I sent in, we sent case studies. For an example of Jay, he came into us very, very suicidal. He'd made quite a serious attempt, which resulted in burns across majority of his body. It took us until he came into us in November, and it took us until January to be able to get him in for an initial assessment in CMHT, during which time he was actively saying he still had suicidal thoughts. From that first assessment in January, it then took us until the middle of March to get somebody to come in and do a review with him. During that time, obviously, we had to put a lot of extra resources just into that person to ensure that he didn't end his life during that time. Multiple phone calls to CMHT that were left unanswered, multiple emails to CMHT that were left unanswered. And that's just one case that we had. I put an example of, I think, another 3 cases just in that month period with similar kind of issues that we were facing. We're quite low level mental health support. We're not statutory. We're kind of people that you can come to for a chat, and we can signpost you to agencies that can have a bit more power to help. But we're kind of being left to manage quite serious situations in the community that we feel we just don't have the resources to be able to manage. Able to communicate with CMHT and any type of mental health services is critical in our role.
Thank you. That's very interesting, and you paint a kind of grimmer picture than I guess I anticipated. But we live in the world that we live. I'm going to open this floor, these questions up. So I know Jill was keen to come in first there. Jill, your questions, please.
Thank you very much, Megan, and thank you for the information. So my understanding is, you've just shared that it's 200 people that Mind deal with, or the clients that they work with in Monmouthshire. So is my understanding correct? It's free for clients, and the funding comes from town and community councils that input, and you get funding from that sort of source. Are there waiting lists for people into Mind? If so, if there are, is there an opportunity to look at other providers? As I just mentioned, I declared that I volunteer for Base Camp in Chepstow. It's a low cost cooperative, non-profit cooperative, and would, if we looked at a more broad approach of looking at all provisions and opportunities, then perhaps prevent some of this escalation, as you're saying. And the other area, which I don't think you'll be able to answer, which is the CMHT, which is, I guess, the people in the suggestion is that they haven't got enough people working there, even though they've got 2 more, you've said, new people, which is wonderful. So I wonder about the stress for that team, because the information you've shared about that must be very disappointing for them working in that team, knowing that they're not succeeding when they really care about people and they want to do the best they can, which is what you intimated. So I wonder whether that also is an opportunity to start looking at not outsourcing, but including other provisions, particularly, like I say, I know I've got maybe a conflict of interest, but I do volunteer for them. Other provisions such as Base Camp, which, because we know it's a massive thing, we know that it's a massive issue that we've got, and people have come on to how it starts at early age and much earlier than this is only the end, not the end, but the crisis point then of a long-term issues for people. So really about overloading what you've got in mind, and then how do you signpost people to other provisions to make sure that is that they are catered for before their problems get worse. And also, I don't know whether it's yourself or someone from Mum's MCC needs to answer about that particular team and how they're managing and how their mental health and their well-being is if there's lots of sickness in that group. Thank you.
Yeah, so we are funded by, so my team specifically, because we are focused on people with mental health concerns and are experiencing housing difficulties. So we're funded by the Housing Support Grant from Welsh Government. There is a waiting list for us, but we also manage the waiting list. So we've got intensive support with our support workers, but while they're waiting, we also get weekly phone calls from a support worker just to make sure that there's no crisis going on at that point. We do signpost quite a lot because we find that if we can get counselling or therapy in earlier than the point that they're at crisis, it often can avoid it completely. So we do, I think we've referred a couple of people over to base camp, and we've also taken advantage of the new pathways scheme as well quite a lot. On the mental health team side of things and their mental health, I know through informal chats that I've had with them that it is really affecting them. I've had an experience where I've had to ring somebody up who's been sat on the duty desk, and they've said to me, I know this person needs an assessment, but I don't have anywhere to send them. And that must be soul crushing to have your entire day be sat on the phone listening to people in absolute crisis and knowing that you've got nowhere to send them to. And I kind of understand why there's such a high level of sickness, because I think I would probably be that way as well.
Thank you, Megan. That's we appreciate the honesty in your answers there. They're good questions, and I think that the theme is that this is obviously going to be quite a difficult session. Alistair, I know you've got your hand up. You're next in line. Sorry, Jill. Did you have a supplementary?
Sorry, no. I did say that perhaps if we've got someone from MCC could answer about the situation in that particular team.
We haven't got
anybody there.
Unfortunately,
I thought we had Sharon Lloyd online, but I don't. No, is that not okay?
Yeah.
Pre-election.
Yeah.
Okay,
so because I believe because it's the pre-election period, this is the line anyway, Jill. Effectively, that Sharon is simply just observing today. It is a bit kind of disappointing, really, because we haven't got any officers. However, we do have the cabinet member, so this works effectively. So if we can make note of this, both Megan and Jill, for your question, or anybody else, I'm sure the cabinet member is going to be, oh really? But so apologies, Ian, in advance to kind of corner you. So what we're going to do is probably wait to the very end until all the questions got away, and maybe you can try to address from Monmouthshire County Council's perspective some of the concerns. And to be fair, I know you're more than capable of doing so. So if that's okay, we'll do that. So effectively, for members of the public, I let all the members of this committee speak first, then I let the guests speak, and then if necessary, I bring in then obviously our the cabinet member or anybody else that's giving evidence as well. So that's the format. So we're bringing in at the end. Is that okay, Jill? Are you happy with that? Yeah, fantastic. Alistair.
Thank you, Chair, and may I say also, Megan, thank you very much for the report, but also for all the work that is carried out by Mind on a day-to-day basis. I'm sure everyone in the room, as it were, would feel enormous gratitude, and it plays into parts of my question really. It's first of all to recognise also the transparency of your report, which highlights in a way that actually is incredibly helpful, and we don't get in every report such clarity about the declaration of failures and systemic concerns. Clearly that's not something that exists everywhere, but it's very refreshing to have that level of open declaration, so that we can potentially be part of trying to address it. But it is really very concerning, and clearly in writing it, the concern comes through. I think it's just to make the point that funding and capacity would be challenges that I think every public service across the country would be saying they have to deal with. And I'm an optimist, but in this regard, I don't see that massively changing anytime soon. And therefore, it's really with that situation, what do we need to do? What more can we do? And I just wondered on 2 or 3 areas. One of them, broadening the awareness and the capacity within communities to actually support and intervene. Perhaps that's something we can do a lot more about, whether that's through the community councils that we've got, the town councils we've got, to make sure that within every town, within every community, there are groups who can be contacted, who are there potentially to support on a voluntary basis where people are able to do so. I wonder if there's more that we can do there, because ultimately there is capacity within the communities, and there are enormous number of people with the goodwill to help if they're trained in how to help and how to look for the symptoms. And the second thought is, are there particular groups that we should be really focused on, in the sense of looking at some of the symptoms rather than waiting for the crisis to develop? I'm thinking about the farming community and farmers, where there appears to be 3 times the level of death by suicide among farming communities as opposed to all others. And clearly that's a huge concern within Monmouthshire. I'm wondering too about students and pupils who, within the school environment, within the college and university environments, we are aware as public services that there are a great many more mental health challenges that are presenting, and whether there's more that we can do in the training of schools, in that regard. So it's really those thoughts and those questions, Megan, and whether or not any of those would be something you could comment on. And thank you very much.
Yes, the farmers is actually one that we're quite passionate about. We used to have a project called the Rural Relief Project. It was a small group, I think there was 4 of them, that used to go out to specifically the farmers, livestock markets. They had stalls set up, and they built up a really good relationship with the farmers, and it kind of highlighted how severe the mental health situation is within the farming community, that's kind of put to the side because it's not talked about, it's not discussed openly, and there isn't actually that much of an opportunity for them to discuss it openly, because farming is a very busy lifestyle that doesn't leave a lot of opportunity to get out and talk about it. Unfortunately, that scheme was, we lost our funding for it, so that's now gone. We do have one rural relief worker that still has a presence in the farmers, in the livestock markets, and they work quite well with other organisations with them. But it is something that we're very passionate about, and whenever we get the opportunity, we put in for some more funding to get that project back.
Thank you for that, Megan. Alistair, have you got any supplementaries?
Yeah, it's just perhaps on young people, and if there's more we can do in communities, in the existing structures, around community councils and town councils. That is there more that you think we could do, Megan, to as a council, as a county council, to help you in trying to engage with those groups who are wonderful people, and their great desire to support and help. And it may be that we can do more within every community by going down a structured approach like that. But also just on schools and young people, if you've got any comments on what might appear to be a growing development of increased numbers with mental health challenges. Thank you.
Yeah, I think it is something that we need to look into. It's not something that our team have at the moment, a youth project, but we're finding more and more, especially the last couple of months, funny enough, that we're getting people that have literally just turned 18 get referred to our service and they're already at crisis point. They're kind of being sent to us as a, can you please take this on now? Because we deal with individuals 18 over. They've got to get to that point before they come into us. One interesting thing that we do have, obviously we've just merged with Newport Mind and they have a youth scheme. So they go into schools, they work within certain schools as kind of like a wellbeing officer. They also have youth counselling, which is something I think we're going to look at to extend, but obviously we need money for it. But yeah, it's something that we need to look at because we get people in, like I said, at 18 and they're already at crisis. And maybe if something had stepped in before that point, it wouldn't have got there at the point where we have to step in then.
Thank you. I think, Alistair, I think Megan's covered those points there. I'm going to bring in. You're welcome to come back as well, Alistair, later in the. If you can think of anything else while you're there. We've got. I do apologise, Malcolm, if I've got this wrong. I've got on my list. I've got Steve next, then you. Are you happy with that? There's the other way around.
Yeah,
It's Malcolm first.
Malcolm, bless you. Sorry.
Okay, thank you. Oh, thank you, Chair. Thank you, Megan, for your report indeed. And Alistair's covered a lot of what I wanted to say, but I just want to raise a question about what's often called postvention, I suppose, support given after suicide. Now, I've been a priest for 25 years and I've dealt with family traumas on many occasions. And recently, a friend of mine took his own life, a school friend actually, of 60 odd years, and jumped in front of a train. So we know that suicide doesn't just only affect the person who dies, it has a wide impact on families, friends, witnesses, emergency responders, and professionals such as train drivers. In this case, I'm thinking of the train driver. And many of these people experience shock, trauma, reactions, I suppose, and complicated grief, and sometimes over a long period. At the same time, we are all aware that mental health and bereavement services are under significant pressures. We know, and we've heard about this morning, with limited resources and long awaiting times in many areas. So the question I'd like to ask is just this. Given these constraints, what forms of post-suicide support have the greatest measurable impact in reducing long-term psychological harm across these groups? And where are the biggest gaps in what is currently provided? And we see from what we see in practice, some of the most effective approaches seem to be relatively low cost, rapid contact after a death. So clear information about grief after suicide and having a single point of coordination so families are not passed between services. And we heard a little bit about that, haven't we? So that's my question, really. It's after suicide, the dealing with people like train drivers, how are they helped? Because their trauma can be long-standing. That's my question. Thank you.
No, I think that's a really important point to make, because it's statistically people who are closest to somebody who has ended their life are more likely to end their life as a result, which can be contradictory to a lot of what people believe, because they think, well, you've seen the impact and blah, 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 but that's not how mental health works. It's very rarely logical. There is help out there. The difficulty is getting people into that help. I'm really sorry, there is a specific agency that I'm thinking of that provide support for those impacted by unexpected deaths, and I cannot remember the name of it at all at this present moment. I'll have to send it afterwards. But there is agencies out there. One of the biggest things that I've learned in the last couple of months is that actually the police, who end up being the first contact for a lot of people, informing people of people who have sadly ended their lives or passed away, they are actually given specific training now, and this has happened in the last year, of how to interact with family members and friends who they have to inform, because previously I think they were kind of left do that as they want, and it was sometimes because they have to be very cold and very clinical, and but I think they have had specific training now that they need to complete. It's mandatory, and they have. I think that is it, Cruz. Sorry, somebody just put it in the chat. Thank you. Yeah, they have projects that they can kind of refer into. It's something that I think needs to be looked at for younger people quite a lot, especially people who have had family members end their lives, especially parents. There are youth mental health teams that can step in, but there's quite a high waiting time, which is where we end up with people in crisis. I think I've used a case study previously of a young teenager that found the body of their father, and it took probably about 2 years to be able to get them into counselling, which I think was partially because of their resistance to it, but also there could be probably more mentorship rather than counselling, because counselling when you're a child is quite scary. Maybe some more informal mentorship would be quite a good thing.
Yeah, thank you. I think, may I just follow on with that, please? There's also an important role for community and faith groups here in providing, I suppose, early pastoral support, which I've done and I do, you know. I sit alongside families who have been traumatized, you know. Admittedly now I'm semi-retired, but I'm still, you know, called upon to sit alongside families, and I do with you know, with no reluctance at all. So I suppose the underlying question is, where can we get the greatest benefit for people affected by suicide using resources we already have? And how can we better coordinate clinical services, voluntary organizations and community support? But I think you've covered a lot of that. But that's my, you know, I'm involved with families and I sit alongside with families, and I'm currently at the moment sitting alongside a widow and her two sort of grown-up children, but they're asking questions and I cannot provide answers. But the fact that I'm sitting alongside with them and talking it through, I believe I'm adding some value to it.
Thank you, Mark. Megan, before you answer that, so what I'd recommend is any elected members that haven't had the suicide training, I think there should be another opportunity and coming along, and certainly for cabinet members, I know they have they had their training yet? No, they're due to have theirs. So, you know, just to interject, whilst the police, you know, we deal with the community on a regular basis. We all go out there on a regular basis. We talk to people on the doorstep, in the street, etc. Take emails. We still have that human interaction, so we're well placed, along with the police, to assist, much like Malcolm has been doing for many years and very successfully, and we thank Malcolm for that. Malcolm, is there any other questions that you've got? You've covered it off there, and Megan, I think did you want to come back on any of those points?
I'm okay.
Sorry. I did want to add that we do have training within Mind as well, if anybody was interested in that for their organisation. We have mental health first aid and suicide awareness, and I would also recommend Assist. We don't run that, but I would recommend the Assist training to anybody who's interested in helping people who are thinking of ending their lives.
Okay, that's fantastic. I wonder if we could just remind people and put that up on our website. Maybe we can get the comms people on the follow-up of this meeting to then just remind people and basically send out a press release and remind the community that, you know, we do have, you know, if we can't help them directly, that we can signpost people. I was approached by a councillor recently who was concerned about somebody that was close to them, and, you know, we successfully signposted them as well. So it impacts on everybody, not just how can I put it? You know, members of this committee. It's everywhere, isn't it? Steve, you've been very patient there. The floor is yours.
Thanks, Chair. Thank you, Megan. Just thinking about your plea for some financial support. I know I'm a Monmouth Town Council and we do support you, but there might be some benefit if you have any specific projects you could go back to we did have someone come to talk to us recently on Monmouth Town Council, but maybe if you've got a specific project that needs funding, maybe go back to the community and town councils and see, if you get a package together of what you need, it might be worth going back to those councils and seeing where they are. Obviously budgets are being decided for next year, but if there's any occasionally we have earmarked reserves that then don't get used for specific project, there might be some scope to come back to us and longer term to see if there's any extra funding for specific projects. That might work.
Oh, brilliant. Thank you.
Yeah. When you mentioned about the charity, the counselling, I did cruise about 30 years ago when I was a teacher, and I know that it was very helpful to me. And I think there's at secondary schools, there's probably an issue with having young people counselling each other, because then what do you do about the counsellors as well if they have trauma and also confidentiality? So it's really got to be with the teachers and support staff. But I don't know whether crews are still active within the area and whether there's scope to maybe go back to the education team and say, is there any potential for training for staff that might be interested? Because if each school had maybe a couple of staff that were available, that might be good for each school to have staff that have got that experience and training and support behind them to help. I also used to be a nightline at university, and I just did a quick check, and I think they're kind of shrinking as they were. But I mean, that you've obviously got young people involved in counselling, and you go through quite a lot of training to become a nightline counsellor. Certainly in my day. So is there any scope to go and look at the universities in Newport and Cardiff and see if they have a nightline, and maybe they might have young people that are trained that might maybe go to capable outreach or engage with younger people in the community as well. Also, you talked about signposting. I don't know how much you signpost the Samaritans, and again whether that as MCC if people can't get through, are the Samaritans mentioned on their answering machine message, for example, or is there some way that a person who's in crisis, they're not immediately going to be thinking, who else can I ring? If there's no answer, that could be a real trigger. So what can we do more to make sure that people don't just get an answering machine message or no answer at all? What measures could we have in giving them a toolkit, maybe when they're sitting at home, even if they've got a leaflet or something with good contacts on it, might be more helpful than to give them at least that there are other people out there. My main question was about the Monmouth, the floods, the Storm Claudia floods, not just Monmouth, but Scanthriff and Abergavenny. And I know you did sessions in Monmouth. My wife attended one because I was also flooded. What do you do? Have you got any plans longer term to maybe support people? Because a lot of people still go through the crisis. Last week we had a meeting in Monmouth at the Robin Hood, and there was a lot of people there who were still quite traumatized by the experience and seeking answers and apportioning blame, and but they are in crisis still. So are you doing any more to outreach to those people as well? Thanks.
So in regards to the voicemail situation with the community mental health team, I think that has got a bit better since that meeting towards the beginning of the year. Our experience now is that more calls are being answered, which is amazing. Before, it was literally just you would ring up and it would either just go dead, or there would be a voicemail saying number 546 is full at the moment, please leave a message after the beep, and that was it. Our experience is that's got a lot better since the beginning of the year. We're getting more answers straight away. We do actually, with our clients, we have these tiny little pamphlets that are probably only about that big, that is a safety plan, and that lists stuff that you can do if you're in crisis, things that help, things that people who you can call, and then on the back we have things like the Samaritan, the call line, all of that, all of the helpline numbers that they can ring, which we've had fed back are quite helpful to a lot of our clients, because sometimes when you're in that crisis mode, you don't want to be scrambling around and googling numbers and trying to work out who to ring. So maybe some more generic leaflets like that to those that are accessing the service would be quite good. The other issue that we do find is the 111 service. Obviously, we've been advised now that people who are in mental health crisis cannot just attend A&E. They will be turned away and asked to call the 111 service. We've actually had a number of people do that and have been on hold for 40 minutes and then be hung up on when they got through, which is not great if you are calling to say, I'm going to kill myself. It works really well for some people, and for some people it doesn't. Some people need that face-to-face, it's going to be okay, which you don't get over the phone. So that is something that we're bringing up and trying to find a way around with the community mental health team. I'm really sorry, I've forgotten the second question.
So I was talking about crews as well, in terms of whether we could do more to encourage staff. I'm not sure what other training is available, but teachers at school to maybe engage in some training to support pupils who've lost a parent or are going through a crisis, because obviously sixth form students might be good, but the confidentiality is always going to be an issue with young people, and especially if they're in the same school and peers. You do need somebody who's at least outside the environment, maybe, to be, so people can trust that they're talking to that person won't lead to it being talked about elsewhere. And I mentioned about Nightline as well as the university age students who are, whether there was any scope to contact them. I don't know whether Newport and Cardiff have those groups still, but I remember when I worked for them, and I led the branch in Manchester in the 90s. It's kind of it is a really good system, and I know university students probably would be keen to help if there was any scope for that as well. Or make this their service available, their number and whatever. Thanks.
Yeah, no, I think that would be a really good service to have. I haven't really have much input with younger people's support, so I'm not really sure what is out there for them. My colleague come in because she's part of the wellbeing team, which have a little bit more knowledge on that. But yeah, I think we know that the call line, which is more of a text support number for young people, it is something that gets used quite a lot, especially in the younger demographic, because they can sometimes think that talking through things are a little bit too complex, so putting things in text form is something that they find easier to access. So maybe those services would be good to kind of put more emphasis on, especially for young people.
Thanks, Steve. Did you want to come in, Penny? Did you want to just interject briefly?
Well, I'd like to ask.
Yes.
Thank you. Can I just go back a minute, Megan? When you say 111, do you mean 111 option 2? Because that is a single point of contact, which is fantastic. And it is, if it's 40 minutes wait, then it's because there's a whole raft of callers, because there's a few callers there at all times in a dedicated room, and it is very good. But did you mean option 2?
Yes, sorry. Yeah, when we went option 2, and I've got to be fair, for the majority of our clients that ring, it's an amazing service, and they're able to suggest things that most people wouldn't think of. They're able to arrange assessments if that's what's needed. I think it's just for those select number of people who, for example, we had one lady that turned up to A&E because she had the items to end her life in her possession. She couldn't keep herself safe, and they told her she needed to go home, ring 111 option 2, and when she did that, she couldn't get through for 40 minutes. Which in that point wasn't helpful for her, but for the vast majority of people, it's a really good service. Yeah,
and at night time too. But that so I just wanted to point that out. Sorry, and I'm sure it'll be spoken about more by the health team. So I'll leave that. What I was going to go back to is the education question, and certainly in my time, in previous time, in council, there was in secondary schools, there are dedicated staff training, member of staff that's trained to deal with these problems, mentored by a specific member of staff within Monmouthshire County Council. And they have posters, dedicated room, lots of sessions, one-to-one sessions if required. So the pupils are aware that somebody they can turn to at any time, and therefore further treatment. But it's something I don't quite know the system now. I can't see why it would have changed, but it certainly seemed to help the situation. It may have expanded. I don't know. And that's what. Could I ask a question now?
You can. That was
just
a cheeky to kind of squeeze in before.
Just to help people.
Marion, I'm sure Marion was paying attention.
Sorry.
No, I'm joking.
I was just going to say, yeah, it's been mentioned, but your staff must be deeply concerned with the systemic failures that have been going on, as illustrated in the case studies, Megan. Do you have a high incidence of sickness within your own staff, the support staff, because of these anxieties that must, arise? And have you noticed a difference, a positive difference, with the arrival of the 2 new CPNs?
I've got to be fair, our staff team, we're very good at debriefing within our room. So we basically, we don't work from home the majority of the time.
Good.
So there's always multiple people in the office, and sometimes you can go into their office and everybody is
so good, isn't it?
Having a little bit of a rant and rave, which is allowed. But we have had some sickness because basically people have said it shouldn't be this hard to help people. That's one of the lines that get fed back to me quite a lot. But we're quite lucky in our team is that we've got quite a high retention. I think the longest somebody's worked here is about, I think it's 25 years. And we don't tend to have quite a lot of high turnover staff, which helps the clients as well, because they always know that we work with somebody for up to 2 years, if not more. During that time, they would have probably met every member of our staff. So they always know that they can come in and talk to somebody.
Great, thank you.
Yeah, thank you. Marion, please.
Yeah. Have I got a question?
Yes, you have.
Has he got a hand up? Which isn't on here.
Megan's more with mind, isn't it?
Yes.
Megan's more with mind, isn't she?
Yeah.
So my question is more directly at an Iron Bevan Health
Okay,
Board.
well, we can hold on to that.
Yeah, is that okay?
No, sorry,
Yeah.
I didn't want to catch you out there. Just
Right, no.
Make sure you were still with us. Okay, thank you. Yeah, so this is the... Sorry, so we've got... Oh, Jill, do you want to come back with another question?
No, I just wanted to say there are talking about what's available in the communities and first step before they get to crisis. The wonderful Andy's Mind Club in Chepstow, and we've got also in Together Works, there's some mental health, mindfulness groups and other opportunities. So there's a lot out there, and also in schools, the setup where short of people, I understand there's short of people counselling and support for young people, because the ELSA is only when an issue's been identified, but hopefully going to work towards having more social emotional learning in schools for all pupils, and therefore that hopefully will help longer term. That's an aim of some people, so hopefully we'll get there. But there are some wonderful things happening, and thank you very much for everything you do, Megan, and all your colleagues. Thank you.
Thank you, Jill. Right, so I was going to get ahead of myself as well. I forgot, actually, we've got members of the cabinet. Sorry, we've got a cabinet member, and also we've got a number of backbenchers there. So we've got Emma, and then we've got Tudor. I'm pretty certain, knowing those two reasonably well, that they'll have questions. So I'm going to let Emma go first, and then Tudor, I'm sure he's got a question. And then I'm going to bring in Ian as well, who's obviously not going to be at all in any way, shape or form. He's going to stick to his brief because we are effectively in that pre-election period. Sorry.
Yeah, thank you. I have no specific questions, though I did try to share some helplines in the chat that specifically for directed at farming communities, if that is helpful for people.
Just put these in.
Okay. All right, thank you. Tudor. Your mic's off, Tudor.
Yeah, can get my mic up. Yeah, thanks. Thanks for the presentation today. It's been very informative, and it's more of a really brief comment. But I was in teaching, also worked for the Welsh Exam Board, and I actually dealt with issues like this as a senior officer. But what I would say is, to me, I think there seem to be increasing pressures on. If you look at younger people within school, and particularly within secondary school, the pressures of social media and friendship groups and so on, and the pressures of exams. There's far more sort of emphasis today on sort of outcomes, and then possibly say when most people in this room were in school, and I do feel for those. I hope that there are sufficient sort of resources to actually help those people, those particularly adolescents, who are going through quite a challenging time. A long time ago, I taught children in that age group, but it is a very challenging time for them. But also you've got the challenges of adolescence, exams, peer pressure, and so on. And I do feel, I think there's probably greater pressure than just hope. Perhaps the cabinet member can answer, but I hope that there are more resources to actually support those people. Thanks.
No, thanks, Tudor. Megan?
Yeah, that is something that we're finding, and I think especially on the younger people now, there's more pressure to be more politically aware as well. Whereas when I think a couple of years ago, you didn't have to really think too hard about what you went and bought, what products you're using, what's going on in other countries. Where now you're getting that fed to you constantly. We're finding that not only is it internal pressure of I need to do well on exams, I need to get into uni, I need to get a good job, I need to do this, I need to do that. You're also getting and the world might blow up at some point. It's a lot for young kids to deal with, and I think having somewhere safe to be able to express those feelings where you're not going to get maybe ridiculed as, oh well, you can't do anything about it, so why worry about it. I think resources like that really need to be looked into, and kind of a reassuring of it's okay to be worried about the world.
Yeah, thank you, Megan. There's certainly a lot to be worried about the world, isn't there? And probably for a long time. I think also, I think obviously social media. So I'm going down a rabbit hole now. I do apologise in advance. But we're going to bring in Ian now. So I'm going to ask Ian to be on his absolute best behaviour now. You know how it is with cabinet members. Once you invite them over the threshold, it's a bit like vampires. That it can be quite interesting. Let's put it that way. So, Ian, the floor is yours. If you want to just effectively try and address some of those points or summarise for us on behalf of Monmouthshire County Council, that would be great.
Yeah, well, I'm not sure I can summarise because it's been quite wide-ranging, but I will do my best, and I will try and be as apolitical as possible in this. But it's a difficult one because it is such a charged issue. So in terms of, so try and speak more from the perspective of the council and the service. There are a few things, but I think it'd be interesting when we get an Aaron Bevan in the room as well, because obviously it overlaps a lot with that. So a lot of our support, well, let me bring that back a bit. So as part of our collaborations with the Health Board and with the Regional Partnership Board, we have the Integrated Service Partnership Board for Monmouthshire, and then the Neighbourhood Care Networks for North Monmouthshire and South Monmouthshire, and that's partnership between health, the council and third sector organisations. So I know we work with Mind. I'm not sure if Mind are formally represented on those bodies, but that's certainly part of it. And we do a lot of within those NCNs, the Neighbourhood Care Networks, we've got the Wellbeing Links coordinators as signposting towards other services, including Mind and others, Men's Sheds, all those other types of things. So there's a lot of work, there's a lot of signposting, there's a lot of different things going up. Whether it's enough, it's never enough. Nothing is ever enough. So we can look at that. I would suggest that when we're looking at mental health and we're looking at suicide, we need to look at particular cohorts. So rather than it's looking broadly across the spectrum, I think we need to disaggregate a little bit by age and also by gender and other factors as well. But those are probably the two determining ones. Within schools, with young people, certainly we've got the Child and Adolescent Mental Health Services, CAMS, that are working. From a personal point of view, I think it's a good service, but it doesn't reach enough people because it only reaches adolescents when they're at crisis point, and it's not actually able to provide an early enough intervention to prevent problems turning into crises. So I think that's a challenge that we have to face. And I don't, as it is a resourcing challenge, and what you've been talking about, other sort of more the roles of other pastoral care or peer support to do that, I think, is something that we need to address. And I think even within adolescence, again, look at the gender issues around that. I do think, if it's not straying too much into politics here, that we need to look at issues around misogyny, around that toxic masculinity and the impact that has on girls, as well as the impact that girls have, and boys as well, on body image, because there is an epidemic of both eating disorders and body dysmorphia that affects both men and boys and girls. So I think we need to look at that. So, but then I think if we're looking at adults, there are two main trigger points, I think, that, as my understanding from looking at the stats and the mental health strategy, is obviously postnatal depression. So women during pregnancy and after childbirth is a big issue, and we need to make sure that we're providing that level of support. And that's a question, I think, more for an Iron Bevan when they're in. And then the other is men more at middle age. And the high levels of suicide amongst men. And it's been touched on, I think, by some of the members asking questions about that community-based support, whether it's men's sheds, whether it's sports clubs, whether it's other community connections that people have got. So I think there's a huge role for community organisations in that, as well as making it less of a taboo subject for people to talk about. And I think sessions like this, I think, are really important to be able to try and surface some of those challenges that we've got. So, yeah, I think that's, in terms of the sort of the details of service provision, I think it's a question that needs to be shaped more at officers that have got more of a grasp on that operational detail in terms of how we're providing services. But from a policy and a scope point of view, I suppose that's my summary of where I think we're at. But it's an issue like this it's been. No, I'm a danger of straying more into a political speech making, so I think I better stop it before I get told off. So I will just leave it at that.
Yeah, well, I can see if I'm dragging you away in a minute, but by the head or something. No, he's not allowed. Thank you, Ian. Thank you for that. You've done reasonably well on staying on side there. I've got. This is my opportunity before we go into the next part of this meeting, which is specifically around data and the lack of data, which will this will overlap into our guests who are just welcomed at the back of the meeting, so the Iron Bevan Health Board aspect of it. There doesn't seem to be a lot of data on, relating to potentially kind of the cause and effect of it, and that's the thing that makes me kind of curious, is that there is obviously it's data driven in as much as that there are obviously lack of outcomes or inadequate outcomes is often the case, as we've come across. We don't really see a lot of it, and that's something I'd like to kind of explore as we go into this final year of this term of the council. Specifically, though, broadly across the nation, there seems to be a kind of growing trend, and whilst we've kind of touched on it before, according to House of Commons Library anyway, there's statistical evidence to suggest that almost kind of 2/3 of suicides are men. Do you see that at a local level? What are the drivers of that? And again, I'm not leading you at all, but in light of the fact that, if society is built around, historically and traditionally around families in whatever shape or form they take place, and there's been a significant increase then in people attending family court, we see these incredibly long periods of time where people are just effectively stuck in the system with very, very poor support, advocacy, and outcomes are kind of obviously for safeguarding issues until very recently kind of held back from public scrutiny. Do you think that is a contributing factor to that, or is that something entirely different?
So in our service, we do have quite a lot of males that access our service, and we're finding that the reasons they're coming to us are getting more and more complex. So there's quite a few, like you said, with the fact that they've been cut off from family, and it's hard to know sometimes what came first, whether the mental health resulted in them getting cut off from family or whether the mental health resulted from being cut off. The vast majority of males that we're getting through, and it could be because we're looking specifically at the people with difficulties with housing, we're getting a lot more substance use issues coming through, and that seems to be highly related to the fact that because they have substance misuse, because they're dealing with their mental health, they're self-medicating, they then are barred from accessing mental health services because they're saying that mental health services are not able to successfully intervene with somebody while they're under the influence of drink or drugs.
Yeah.
But then also the drug services aren't picking them up because they're saying that the mental health needs to be sorted before we take away the crutch of the drink or drugs. So the majority of men that coming through to us with suicidal ideation are coming to us because they've been stuck in that situation for quite a while and they don't know how to get out. That's kind of the clients that we've worked with that have unfortunately ended their lives tends to be the cycle that they're stuck in. There are so many projects out there at the moment that are specifically targeting men because that is been identified as quite an at-risk group. I think they're stuck between the traditional role of I need to be the provider, I need to be the strong one, I need to be the one that keeps everything together, I need to keep the family together, I need to keep the money coming in, I need to keep my job, I need to do all of this, and it's kind of clashing with the more modern processes where everyone's saying, come and talk about it, it's fine to be open about your mental health, whereas they're still stuck in the no it's not. And I think it's finding a way of crashing through that barrier of it's okay to speak about your mental health. It doesn't mean that you're weak. It doesn't mean that you're failing. You just need to speak about it, and that's the only way that we can deal with it is once it's out in the open. But I think that is the main barrier with men, is getting them to take that first step into those projects that are built to support them.
Okay, and on that point then, so if we know that, I guess that you've just highlighted some of the issues to do with homelessness, and obviously the pressures of that, and then subsequently, arguably, the thought that the traditional male role is now becoming effectively redundant, or they feel redundant in that role. Do you think that we've got a good enough link then, for example, with housing associations? My father used to be a housing officer. I'll share this with you. And he had a very, very close link with the community. It was in Pill, actually, in Newport. And he understood the community, I think, reasonably well. Very diverse community. Do you think that those roles have changed, where potentially then those officers, or if you've got any knowledge of it, have adequate understanding that it's not... I've got to be careful what I say, because I've got a case on where it's more human-led as opposed to process-led. Do you think there, you could have a better relationship with the housing associations? Do you think you could, provide more kind of up-to-date advice on some of the kind of concerns that you might have about, process and the pressures that people are in? I mean, I'm going to share this. I had a case just before Christmas where literally someone was under, and I'm not going to go into the specifics of it for obvious reasons, was served notice literally just before Christmas, and I wasn't even sure we still did that. I thought that housing associations, effectively, because it was Christmas, a time of traditional goodwill, wasn't a period of time where we were effectively putting people out on the streets. But however, it was the case, and I just felt it was inhuman, really. But sorry, I'm going off on a bit of a tangent here. So I'm sure members will be patient with me on that. But do you think there's room for improvement there with the relationship with housing associations?
I've got to be fair, with our team in particular, we've got quite a good relationship with the housing association.
Okay.
So we've linked with a lot of the local housing officers, and they will, if they know a client is one of our clients, they will reach out to us if they think there's any issues. They will ask for advice on how to deal with stuff. So I think that's great. I think that there could be some more training specifically around mental health that goes on in housing associations that are more specialized, because I think people are able to deal with the traditional mental health symptoms, like depression, anxiety, things like that. When it gets to the point where it's crossing over into antisocial behavior,
Yeah. Okay.
I think there can be quite a lot of training around there, because I think once it gets into the antisocial behavior, it switches to process then straight away. There's no kind of nuance. It's very, you did something bad, you need to go. So I think that could be an area that we need to look into training a bit more.
Thank you, Megan. You've had a lot of questions from members, some very good questions, and I'd like to thank the members for those questions. I'm going to allow the members one last chance to ask you questions. Failing that, then I'm going to say thank you. We really appreciate obviously you're staying on for the next bit then to ask some questions of the health board at the back. On behalf of this authority, I can say that as the chair, we really do thank you for your support within the community, and effectively you're helping provide a safety net, which is something really arguably the state should do better at to facilitate, and you're helping with that. And we, on a human level, we thank you for you're clearly a very compassionate person and very committed to the cause. So again, we thank you for that as well. Are there any other questions on that front? No? Thank you, Megan. We're going to take a short break now, and then we're going to bring our next witnesses in from an Iron Bev Health Board, which is item 2.4. So we're going to have 2 minutes, which allows Miriam to get another cup of tea and everybody to have a comfort break. So I'll see you in a minute. All right, thanks. It's my fault. Stupid. It's Hazel. Hazel. I mean, the poor people. We got. I do apologise, members.
Oh, was that lady?
Yes,
Yes, I thought I recognised because I was there.
Oh, were you?
You were very good.
I was
your
the
voice.
old lady.
Yes, I recognise your voice.
Are we not live? Oh, thank God for that.
You were excellent.
I don't know what's going on here.
Sorry, Chair.
It's just chaos. It's all been so really. You've come along and upset the whole apple cart, haven't you? Yeah. It's the last time. Is everybody with us? So that everybody in line. Emma, you still with us yet? Is Emma still with us? Ian's still there.
I can't hear you yet, Chair.
Okay, Ian's no, he can.
Sorry, Emma.
So this is part 2, and it's an Aaron Bevan. So they've got their presentation.
Yeah.
Turn them on. Camera comes to.
Are we good?
4-2.
Right. Welcome back, everybody, to the second part of the Public Services Scrutiny Committee. I said previously I misspoke. I said it was the next item on the agenda was 2.4, and then Penny very diligently and quickly pointed out it's 4.2. It's part 2. Okay, so we're on part 2 for everybody following us at home. So to receive a presentation from an Aaron Bevan Health Board, and it's effectively a progress update. The format of this meeting will be, just to remind everybody, I'll let members of this committee speak first. We have guests. I'll allow the guests and also the cabinet members to speak. So on my right, I'd like to introduce them, or they can introduce themselves, and then I'll just open it up to the presentation. So.
Good morning, I'm Dr. Lysandra. I'm a consultant clinical psychologist. I've been here with the committee before last July, so thanks for inviting us again.
Good morning, my name is Dr. Emily Clark. I'm a consultant in public health at Gwent Public Health Team.
Good morning, my name's Jackie Williams. I'm a senior public health specialist with the public health team in the Health Board.
Thank you, guys. Right, so you've got a presentation for us. The floor is yours.
I'm not on my team's link because my Wi-Fi went
Yeah.
so I'll talk here.
We've all disappeared.
I've lost it altogether.
Yeah, I think the internet did drop.
Oh, mine hasn't come back.
People are still online, so we should be.
Well, I'm not. Shall I?
There we go.
Shall
It's
I
up.
add this device? Sorry.
Yeah, no, go for it. Sorry, guys. Sorry, I do apologise for everybody watching at home and for other members at home as well. We're just about to. Have we got it up now? The presentation. Was it dropping?
Yes, that's perfect. Keep on it on the screen, see it.
Yeah, everybody at home can see it. No. Yeah, Steve, you can see it. Yeah, that's it. Everybody can see it. Right, the floor is yours. Go for it.
Brilliant. Okay, well, I'm going to speak to Emily's screen because mine isn't picking up. Myself and Louise Turner, who's our Divisional Director for Mental Health, were with committee last July, where we were presenting some of the findings of a deeper dive into mental health suicides. And at that point, we were also orienting to the public health data on suicide. So we're glad to be with you again, just to update a little bit on where we are in mental health and learning disabilities, and really pleased to be with colleagues here from public health so that we balance the conversation somewhat. Unfortunately, Louise can't be with us today. She's not very well, so we'll do our best to field questions from you all.
Sorry, the slides that I've got on my screen and the slides
Static, are they?
on the screen don't quite match up. Yeah.
Hang on.
Sorry, we're all having problems here.
Yeah, I think what it is, the council's internet's dropped, which is very unusual.
This should be going through my phone.
Oh, okay.
Yeah. Sorry. Oh, we've moved to the next slide.
Okay.
It's just taking its time.
Go for it, yeah.
Okay.
Yeah.
Apologies for that. We were just having issues with the slide deck. And it's jumped ahead again now a slide. So I'm Emily Clark. I'm a consultant with the Gwent Public Health team, and I'm here today with my colleague Jackie Williams to discuss around how we can the work that we're doing around suicide prevention across Gwent. So I thought I'd just start with a brief note about self-care and safety. We know that discussions around suicide and self-harm can be distressing, upsetting, and a very sensitive area of conversation. So we just wanted to acknowledge that if anybody either here in the room today with us or listening online, if you need to step away from the conversation, if you need a short break, please do just step outside. If you're listening at home, please do step away from the screens. It's a gorgeous day outside, so please take the time to just clear your head and get some fresh air. If you need additional support, please do reach out to a trusted friend, colleague, or family member. And sorry, apologies, the slides appear to have a mind of their own today. But at the bottom of the screen, hopefully soon, there should be some sources of support that we would recommend you reach out to if you are in need of that today. The first is Mello website, which we'll hear a little bit more about later on. That's MELO. And there's a huge range of information around mental health and wellbeing topics, including resources and where to go for additional advice. We would also recommend the Community Advice and Listening line. The phone number should appear on the screen soon, but that's 0800 132 737 for free 24/7 phone support. And there's also a text number 81066 that should be on your screens now. And for any urgent advice or help, please phone 111 and then press option 2. We know also that talking and asking about suicide does not increase the risk, but we do also know that particular details can increase that risk. So there's certain details that we will not be discussing within this presentation, and that's the reason why. We have some guidance around media reporting and social media, so that should come up on screen shortly. We know that sensitive and responsible media reporting that is non-stigmatising, non-judgmental in its language can really help save lives. So there are guidance available from the Independent Press Standards Organisation, the Samaritans and the World Health Organisation on how to report such conversations sensitively and appropriately. So we'd really recommend that you review those if you're planning to, if you're a journalist listening to this or if you're planning to write up from this presentation. The Samaritans also have some social media guidance. This should be available soon, and we're more than happy to share the link with you all once we have that. And that would be really helpful just in terms of helping us know how to use social media in this topic area. We also just wanted to note that it is the pre-election period, so we have tailored our conversation in line with that, in line with the guidance, and we'd be grateful if any questions and discussion points also stay within that guidance. Thank you very much. So I'm now going to hand back to Liz to guide us through the contents of this presentation.
Thanks, Emily. So we just wanted to reorient all of us to some of the conversations that we had last time. I'll do that on the next slide. And then we'll present to you the publicly available data, which is in the real-time suspected suicide surveillance, and also the information that we gather from the Office for National Statistics. It talks, I suppose, gives us all a bit of a landscape around the people in our communities that are ending their own lives. We'll talk through the current strategy, understanding the suicide prevention and self-harm strategy for Wales, and the Aneurin Bevan vision, the interpretation of that. We'll feed back some of the service developments that are happening in mental health and learning disabilities, and then we'll end with the presentation with priority areas for action before having some questions from committee members. So just reorienting us to mine and Louise's last visit here in July 2025. And I think many of you were there, actually. I recognise some of the faces on screen and also some in the room. At that point, we had done, as we always would, a deep dive into the sudden and unexpected deaths for mental health patients in Aneurin Bevan. And just to remind people that that is anybody who dies of a physical health cause or suicide or suspected suicide. And that often when we're talking about suicide, it's a very technical term, and that is given by a coroner. And so when we're looking at what we consider suspected suicide, based on the information we have as a mental health and learning disabilities division, it's often overestimating someone's intention to take their own life. Often that verdict is given by a coroner, and sometimes we don't actually find out the final verdict. So the data that we present is often an overestimate, and we triangulate all of our data with the National Confidential Inquiry into Suicide and Homicide and also our colleagues in public health. At the time that we visited last, we'd presented a review of a period from 2021 to June 2024 that covered all causes of deaths. And you may remember that there was a preponderance of suspected suicides within Monmouthshire, and we spent some time thinking together about some of the factors that might contribute towards that. I'm pleased to say that in this tranche of data, that isn't actually high as it was last time. Just thinking a little bit about the process within mental health and learning disabilities specifically, any death that we are not expecting is recorded and it's investigated and scrutinised for learning. We take all deaths very seriously, including and especially deaths where people have chosen to take their own lives or people have ended up taking their own lives. Importantly, because we know of the ripple effects of suicide, and I think Emily and Jackie will talk about the number of people who are affected when the index person ends their own life. And we also support all affected parties, including family members and significant others. What we will always say, and you'll hear us saying this lots through this presentation, that intended suicide remains a very rare event and it is also very impactful. Very sadly, of course, what we know is that the majority of people that intentionally take their own life are often not known and not under the direct care of mental health services, which is why we've come today with public health colleagues. That was one of the themes that we spoke about during our last visit. So I'm going to hand over to Jackie and Emily, who are going to share a little bit more about our learning from public health data.
Thank you, Liz. Sorry, we're just having a few issues with the slides. So I'll have another go.
Sorry, Chair, the problem is the council's Wi-Fi has dropped several times during the meeting, so it's thrown some of us out of Teams. So if members can just bear with us for a second.
It's okay. We appreciate everybody's patience on this.
Chair, I wonder if it helps to know that we've got the slides on the agenda and they'd be accessible to the public as well. It might be that would be a workaround.
Sure, I think that's a good bit of advice.
Slides up and then we just reference the number of the slide.
Can we do that?
We can do that. Yeah.
Excellent. Thank you.
Brilliant. So I'm getting the slides up for myself. All right, so it's slide 7. Which is just a short slide where I thought we could talk through the two main data sets that we use here in public health. The first is called the Real-Time Suspected Suicide Surveillance. This is a database which is held by Public Health Wales. It was established on the 1st of April 2022. So we now have 3 financial years of complete data from the RTSSS. Any suspected suicide is reported into Public Health Wales for inclusion into this data set. So that would be from organisations such as the police. And this data is then released annually as a report. But as a public health team, we have more frequent conversations with the holders of the RTSSS so that we are able to quickly identify any emerging trends or themes that we're then able to address for public health intervention. So it does likely overestimate the number of suspected suicides because the The cases included within this data set have not yet gone through that coronial and inquest process, but it does mean that we are able to understand relatively quickly what's happening. The other data set is the Office for National Statistics, so this only includes cases whereby that coronial and inquest process has been completed. So this is the very accurate data set, but there is a delay to allow for that inquest process to take place. So we look at both sets of data in order to understand the picture of suicide in Gwent. So we're now moving on to slide 8. I think it's a bit of a lag on what's being shared on screen. So this is slide 8, looking at key findings from the RTSSS. So what we can see here is the rate, so this is per 100,000 population, of suspected suicide in Wales in blue over the 3 years that we have data from. What we have seen is that the rate is increased for the 24-25 financial year, and this is a statistical significantly increase. So this might be because there is an increase in the number of suspected suicides across Wales. It could also be due to increased reporting into the RTSSS during that financial year. Now we also have the rate for Gwent shown, and that's in green for the 3 financial years. And we can see that the rate has also increased for Gwent, but this is not a statistically significant increase, which means it is within that sort of normal variation that we would expect to see. It is something that we are keeping a very close eye on, and it doesn't mean that we are still working very hard across the full range of public health interventions in order to do as much as we can to prevent any further suicides. In the slides available online, I'm not sure whether this additional slide was included, but I had included a slide on the rates between the different health boards, which just shows in a bit more detail that the rate for Nair and Bevan sort of is within the sort of normal variation that you'd see across the different health boards for Wales. So I'll make sure that that's updated on the available slides online. And then slide 9 it will be is looking at the rates across different local authority areas. So what we can see here is the green local authority rates are those within Gwent. And so the rate for Monmouthshire is 18.6 per 100,000. The other point to note is that this is 3 years worth of data. And the reason for that is that although these are deeply impactful and devastating events, they are still relatively rare. So that's why we have to wait for 3 years worth of data in order to produce some of these figures. So the rate for Monmouthshire here is within that normal variation that we would expect to see. So moving on now to slide 10, and I'll hand back to Liz for this.
Thank you. So we are also analysing in retrospect. So although as suspected suicides and other deaths come to us, they're examined immediately, often within a week. We're reporting and analysing our data in retrospect. So this covers the period July 2024 and June 2020 to June 2025, in which time there were 92 unexpected deaths of patients known to mental health services, and they would have been known in the 12 months prior to their death. So it might be that they weren't under the care of mental health services at the time. And you'll see that just a little over a quarter of those were deaths by suicide or suspected suicide. Few would have been confirmed as suicide. Now the graphs are very small, but what you can see at the bottom is that Monmouthshire is the second lowest in terms of the number of unexpected deaths. And then you can look at the age of people when they were dying. And what we see is often that kind of typical trend of men who are in middle age, so sorry gentlemen, but men between the ages often of kind of 40 upwards, and then we see another trend later on in life, and it is still the case that of all causes of deaths, including physical health causes, more men die than women. And I should say, just thinking about language of inclusivity actually, that although that sounds binary, what we look at when we're analysing this is sex at birth. And that's because not all people have changed their gender on the patient information system. So we're looking at sex at birth, so apologies that it comes across in quite a binary way. So more recently, we are currently looking at a deep dive on data from April to October last year, 2025. And we're here to think about Monmouthshire, so just giving you a little bit of feedback on Monmouthshire. This data for Monmouthshire, that in that period, there were 11 reported deaths that were not expected. And when we say not expected, I suppose it's that we're not expecting it because of what we're predicting from someone's mental health needs. And so what we were finding is that the majority of these are associated with dementia and frailty. So they are older people, many of whom were above the age of 85, dying of cardiac complications or sepsis. So it might be that on the slides that you've got, there is mention of how many cases of suicide there were. We didn't want to present that publicly because it's a very small number. In terms of service developments, what you'll hear us presenting here is saying that actually suicide appears to be a public health problem. Once people are under the care of mental health services, it's an even more rare event that somebody takes their own life. There are lots of support systems in place to encourage people to use help, to seek and use help when they are in a mental health crisis. So you might say, well, perhaps one of the problems then is access to mental health services, and that's why the majority of people that end their own life are not under the care of mental health services. You'll know that there is developments whereby we are working really hard on increasing accessibility across the mental health care system. And we're pleased to let you know that this open access option where you ring 111 and press 2 is now available 24/7. It means that people of all ages can call for urgent mental health support, receive a brief intervention on the phone, and what we would call warm signposting. So that can often be not just signposting you to a service, but also if you're already in contact with services, ensuring that that service are also aware that you've been in touch and that your mental health is in need of support, and then onward referral where appropriate into local services. Coming up now to the kind of current day, we're just in the midst of a pilot which integrates more highly specialist crisis assessments and urgent referral pathways into that service. This ensures timely access to assessments and support for service users and also to referring professionals. So there will be an advice line for professionals ringing in, because we know that our colleagues in the broader health service, including, for instance, Welsh Ambulance Service or GPs, often need support when they're supporting somebody in a mental health crisis. What we might sometimes find is that professionals know that somebody needs help, but the person themselves are not willing to access help or don't feel able at that time. And so it's about guiding the people, if you like, the village that are around the index person. So the urgent crisis assessments are co-located with our practitioners in 111 Press 2. And so this is all moving towards the given direction in Wales about a single point of access for everybody with a mental health difficulty. So streamlining that access point and getting rid of some of the confusion about who goes where. So that's our updates. I think I hand back to Emily now.
Thank you, Liz. So we are the public health team, and we think a lot about prevention within public health. What can we do across the board to reduce the risk of suicide? So one of the key things that we want to think about in that space is what are the risk factors for suicide? So we know that suicidal thoughts are very common. So a survey across England and Wales recently showed that there's about 1 in 4, 1 in 5 lifetime prevalence of suicidal thoughts. So that's startlingly high. And we know that there's a number of risk factors as well for suicide, but not one of these risk factors in and of themselves, but it's probably a multifaceted interplay between a number of different factors across people's cultural, social, environmental, physical elements all coming together. So some of these risk factors include previous self-harm and a previous suicide attempt, people's physical and mental health, socioeconomic inequalities such as deprivation, debt, unemployment, and economic inactivity, relationship issues or family issues or problems with work, domestic abuse, sexual violence, and that's from a perpetrator perspective as well as a victim and a witness perspective as well. And we know that prior experience of the criminal justice system, for example, can also confer that increased risk. As Liz alluded to earlier, we also want to be thinking about the impacts of suicide. So research has shown that around each death by suicide very sadly affects around 135 people. It's likely actually that this may be higher given our interconnectedness through things like social media and the way that we live now. So and we also know that each death is hugely impactful to a huge number of individuals, and that's their long-lasting impacts. We know as well that being bereaved by suicide, it may lead to relationship breakups, unemployments, financial problems, worsening physical and mental health. And so actually thinking about bereavement by suicide as a risk factor as well for suicide. So we are thinking about all of these components when we think about how do we go about preventing suicide here. And that's why, so I've got a graphic, it's slide 13, but that's why we feel that suicide prevention really is everybody's business. So we all have our part to play as a friend, as a family member, as a professional, and in our personal lives as well. Which brings me through to our vision. So our vision for suicide and self-harm in Gwent is that every single person affected by suicide or self-harm feels safe, feels understood and feels supported within compassionate and informed communities. We want anyone experiencing thoughts of suicide or self-harm to feel empowered to seek timely, accessible and person-centred care that meets their needs when and where they need it. And we want organisations serving those living in Gwent to work together to really strengthen the focus on prevention. So I'm going to hand over now to my colleague Jackie, who's going to go through all the work that we've done so far and where we see this going in the future.
Thank you, Emily. So yes, so we hear from the Health Board and the Public Health team, but what we're going to be presenting is work we've been doing in collaboration with a wide range of partners. So back in 2020, the Public Health team initiated a steering group which brought a wide range of partners together to start considering what we should be doing on a Gwent-wide basis. So that steering group has been developing annual delivery plans since 2020. And we've had so much interest from partners that we've initiated an expert advisory group as well, which is made up of a wide range of organisations across Gwent and people with lived and living experience of suicide and self-harm. And they come together on a quarterly basis and help ensure that the delivery plans are based on local intelligence as well. So our most recent annual partnership event was held last September and was held in person in Gwent, and we had over 50 different partners coming together, and we considered national and local evidence and wider plans. And we've pulled together a delivery plan for next year, an annual delivery plan, and also a regional framework and strategy. And we're very happy to share that with you, and I'll be able to explain the mechanisms we propose to share with all our partners. But that basically sets out how we're going to achieve the vision that Emily outlined. So one of the things we've been doing on a regular basis as well since 2020 is reviewing police data. So police are often the first people on the scene of a death by suicide. So that's suspected death by suicide. So it isn't a confirmed, it hasn't gone through the coronial process, but is a suspected death by suicide. We come together with the police on a regular basis to look if there's any themes or trends or anything we need to be intervening early. And that has actually resulted in a couple of task and finish groups which address some of those high-risk populations and locations of concern. So we've done some really targeted interventions which has resulted in awareness campaigns. And for those of you that are in the room, I'm going to share with you the lovely leaflets that we produced in collaboration with a local group of people, a peer group of people that had been affected by death by suicide, and they've helped us to pull together leaflets. I don't know if you can see those on the screen. I don't know if you can, but I'll leave some of them here in the council offices. for you to be able to disseminate as you need to. The other task and finish group focused on a high-risk population group, and I know that's already been alluded to. We've had discussions about men being at higher risk of suicide. So we've done some really targeted work with men, in particular rugby clubs, and that has led to further funding that's been received from one of the local charities based here in Monmouthshire. Some of you may know it, the Ted Senior Foundation. They have funded one of our local third sector partners to, I suppose, not only enhance but widen the impact, the project that they were leading on. So they're going to be developing a project in collaboration with wide charities that are targeted on supporting men, like Men's Den, You're Never Alone, those sort of charities. They're all coming together this financial year, and they're going to be delivering topical talks to men. They're developing a men's mental health toolkit and ensuring that the men have that easy access to talking therapies. So that's a really good piece of work that's come out of just by looking at some of that data and identifying some of those high-risk populations. The public health team have also ensured that we have had access to ongoing funding for suicide bereavement support services as well. So you may be aware that people that have been affected by a death by suicide are actually at higher risk of mental health and emotional problems themselves, and also potentially suicide. So there's a lot of evidence out there to say that there's a real positive impact if we can provide specialist suicide bereavement services to sort of aid that grieving process and reduce potential contagion as well. So there's a national service now called the National Advisory Liaison Service that provides support for anyone affected by a death by suicide. There's also another national service some of you may be familiar with called 2Wish that provides support for anyone affected by a sudden death of a child aged 25 and under. And specifically in Gwent, we've funded an organisation, the Jacob Abraham Foundation, to ensure that there really is additional support to the national service for anyone affected by a death by suicide of somebody aged 26 and over. And there's a really good process in place with police. So when there is a suspected death by suicide, the police can refer those families and friends directly to those services. There's no waiting list for those services, and they offer that tailored support, whether it's face-to-face or telephone support. So there's some brilliant services out there. We've also ensured, and some of you have experienced it, that there's support for, there's funding available for training as well. So we know that suicidal thoughts are really common, and as Emily already said, a quarter of us can experience them at any time in our life. So it's really essential that we all know what to say and how to signpost people if we come across somebody that's experiencing those suicidal thoughts, because they might not all present to services. They might want to talk to a friend or a family member, a hairdresser, a barber. So we want to make sure that everyone has access to those free training courses. So I was going to talk you through the Mellow website. I hope I can. If not, we'll make the best of it. But just to signpost you all to free training. There's a wide range of online training courses that are available. And also there's the Gwent Connect 5 training as well, which is face-to-face training. And I know some of your Monmouthshire County Council staff are trained to deliver that training as well. So if we have the opportunity, I'll talk you through the Mellow website and signpost you to where that training is available. Another thing that the public health team have been doing is, since 2020, is developing a mental health and wellbeing website, the Mellow website. Some of you will be familiar with that website. Since it was launched 5 years ago, we've had over 185,000 new users. which is phenomenal. We're really proud of that, and we do seek feedback on a regular basis, and that feedback is overwhelmingly positive. There's 37 different topics on that website. Suicidal thoughts is one of those. Self-harm is another. But there's such a wealth of information on there. There's over 350 resources, 70 self-help courses, and 80 helplines. So if you're not familiar with the Mello website, I would really encourage you to have a good look at that. It's not only for members of the public. We know that professionals use it as part of their everyday work as well, whether it be mental health staff or housing staff. They're all very familiar with it. It's also used by HR officers, for example, to support people through bouts of sickness that might be related to mental health and well-being. And then the last line on that slide 15, refers to our Padlet, which we've just developed as well. It's more for professionals, so that would include yourself. It's for anyone that's not familiar with the Padlet. It's like an online notice board, and users can post useful content. So on that Padlet, and we will be sharing a link to that as well. There's a wide range of information, including the RT-SSS data report, the ONS data report, all that information on suicide bereavement services, and also training. I don't know if we can talk you through the Mello website, but on slide 16 is a visual of the Mello website and a QR code. If we were able to use the technology, we were going to talk you through it. We were going to ask you to go online and have a look yourselves. I don't know if you want to do that now, but if you have a look at the QR code, I can talk you through some of the Mello website.
What I'm conscious of is that we're...
Time, okay. Okay, sorry, questions. I'm going to move on then, but please have a look at the Mello website. The slide 17 is the Padlet, and again there's a link to that Padlet. Please have a look at our Padlet. It's got some phenomenal information on there that you can share widely. Slide 18, I will go through quite quickly, apologies, but I'm conscious of time. But these are some of the priority areas that are in our delivery plan. And our delivery plan, once it's signed off by our steering group next week, will be available on that Padlet, so you'll be able to look at it in greater detail. But we're really conscious we want to be listening and learning and understanding the evidence and local intelligence, so we're establishing an intelligence subgroup. We're continuing with our data review group, and also ensuring that we're listening to lived experience, so that all our work is informed by people who have got experience of suicide. We're also establishing a communications and engagement and training subgroup, just to ensure that we can get this information out as wide as possible, because we're conscious that we've got a lot of excellent resources and training, but how do we ensure that everybody else knows about them? And again, we've alluded to some of the risk factors around suicide, such as housing, so we're working really closely with our partners in housing, VAUDA SV as well, that's violence against women, domestic abuse and sexual violence. Same with our drugs and alcohol partners, ensuring that they have access to training and all the resources. Sharing the Padlet as well. We'll also be launching a task and finish group for workforce and a staff mental health well-being, because we want to ensure that those staff, frontline staff that are doing the supporting, are also supported themselves. I will just flick through some of these priorities. I'm hoping you will have a chance to have a look at our framework and our delivery plan yourselves once they're published. But one of the exciting things we're doing in the Aneurin Bevan area, which is a first for Wales, is we're piloting a suicide prevention service. So acknowledging that not everybody that might be experiencing suicidal feelings will be, will have a mental health condition. Their experiences might be more related to relationship problems, finance, housing, bereavement. So we're ensuring that those people have access to specialist support, and that's going to be launched later this month.
Thank you. Thank you.
I'll leave it there. It's just the final reminder around self-care and services.
That's it. Right. Okay. I'm just conscious of the time, and so I don't want to kind of shortchange anybody really. I'm going to take the unusual step of just asking a question at the beginning. So please forgive members my. So if you look at the graphs that you facilitated, it shows that Monmouthshire is third on the list. It's the third highest suicide rate across all the counties that are listed there. And yet when you've put the resources into it, the pilot scheme you've run out of Newport, which is the second lowest. Why did you do that? The other questions relates to then the lack of continuity over cover arrangements as well, especially where it says, if you look at the previous document, it says clients are not being informed when their community psychiatric nurse, the CPN, is being absent. There's a lack of clarity regarding temporary alternative points of contact. Failures to follow through on commitments to call clients or workers with updates or safety plans. These gaps have left clients without support during periods of acute need. Can you address some of those points? And then I'm going to bring in Penny, and then maybe not, I'm going to bring in some of the members who've got their hand up, Steve, Jill, and so on and so forth.
Can I just check the pilot scheme that you're referring to? Do you mean the one that Jackie just mentioned? The suicide prevention?
Yes.
It's health board wide.
It's health board wide. It's not
Okay.
No. Yeah, so it'd be health board wide.
Okay.
Yeah.
So could you just give us where that's played out in Monmouthshire, specifically in Monmouthshire? It hasn't been launched yet. Okay.
Yes, so the pilot service is going to be launched later this month, and it's Gwent wide.
Okay. All right.
And then I think the other points that you're referring to would be in the prior agenda item, aren't they? So they're in the concerns that have been raised by Monmouthshire, by Mind in Monmouthshire.
Yeah.
So my understanding is that the Mental Health and Learning Disabilities Division have met with Mind and will probably address those concerns outside of this meeting.
Okay.
It's probably the most appropriate place to do it because it pertains, having read the report, it pertains to some specific individuals. So it's sensitive information.
With that in mind, because I always like to get to the truth, the reality that the public have a right to know, and I take all your points. So at this point, I mean, Megan will obviously be best to answer that. I'm going to bring in Megan to then just carry on with those kind of concerns and those questions.
Okay.
Megan.
Yeah, we did meet on the 27th with one of your members of the team. I think like I said, the issue with communication has kind of improved quite a lot since January. So they've been answering the phones quite regularly. The getting back via email is still a bit iffy, but we've been given contact details for kind of the higher ups within the service that we can go to if we're not getting any responses back. I
mean, I guess that's hard.
I think it's yeah, sorry.
Yeah, I was just going to say, Megan, that's a bit more heartening, isn't it? So my understanding, and I don't want to speak too much about some of the clinical sensitivities, there's, the case descriptions that are given in the report are parts, or I suppose those of us that would know are identifiable. So thinking about it more broadly, operationally, my understanding is that the meeting with the Mental Health and Learning Disabilities Division revealed that there was an operational problem, that it was a wrong phone number, and that's been addressed. So hopefully that eases some of the points of contact, but also the reminding people that the 111 Press 2 service is available to professionals as well. So that would also be a second point of contact. It sounds like some of the way for contacting the team has been eased. I suppose the other thing to bear in mind is that if we're emailing individual clinicians, they're clinicians, so they will be out on visits or with patients or in kind of clinics where they're administering medication. So then they're often not sat at desks. But I'm really heartened to hear that there have been some more points of contact given to Mind colleagues.
Yeah, I think yeah, I won't go into details obviously about the case studies, but I think the getting backed by email, like the situation that I'm thinking of, I kind of emailed 3 times over the course of 3 weeks and received no response back, which I appreciate. People are busy.
Yeah.
But over the period of 3 weeks, you would think somebody would have an opportunity. But obviously, I don't want to go into detail about the specific case studies. But overall, I think it's getting a lot better. And I think we're taking up the opportunity that they've asked us to go into MDTs to kind of get a more personal relationship with those working within the team, which I think would be quite a good thing, because at the moment it's kind of, we're all kind of behind different screens and nobody knows what anyone does and there's no kind of relationship. So building up that relationship, I think, would be really important.
Yeah, the idea about having a relationship with a system and like smoothing those interfaces between us is the ideal situation for anybody experiencing a mental health problem, that there's almost a village or an ecosystem around the person with as smooth as interface as possible. And I think that can only ease care and the relationships between all of us for the good of the majority, isn't it? So I'm really pleased to hear that. And certainly there are some models in some of the other local authorities in Aneurin Bevan that it would be really good to learn from each other. So some kind of close partnerships with the third sector, for instance, in Newport, but also in Caerphilly. So really I'm happy that we're having conversations outside of here with the division so that we can take some learning from some of the other areas as well. And always grateful for concerns to be raised, because if the health board don't know about them, we can't address them. So always really grateful for that. Thank you.
Yeah. So, and I'm going to be cheeky again just because of speed, and we've obviously got Steve and Jill in. So Mallow kind of deal with, I guess, forgive me for saying this, but they're certainly not insignificant issues. They're certainly not low-level issues. But so what I'm trying to get is, who deals with the really complex issues outside of Mallow?
Yeah, so I suppose the way that we often think about mental health and well-being in our communities is a little bit like an iceberg, really. So the majority of people will sort of be at the bottom of the iceberg, and then by the time things have got above the water and there's more severity, those services are your specialist services, in the same way that would mirror physical health, I would imagine. So your GPs are dealing with the bulk of people, then there are some specialists in community services all the way up to acute care. So that's mirrored across mental health. So you've got Mellow, which is your tier 0, kind of at the public health level. Then you'll have primary care mental health support services, and then moving to this open access model. So our primary care mental health support services receive a minimum of 15,000 referrals a year. So they are also well utilised within Aneurin Bevan. And then you'll move up through into what we would call kind of tier 2, tier 3 services, which is specialist mental health teams, all the way up to our acute services. And obviously there's a number of unlocked wards within the health board footprint that care for people with the most severe and enduring mental health.
And I just wonder, so with the more acute cases, are we seeing a lot of that in Monmouthshire? Because obviously the stats speak for themselves. We have a disproportionately higher, compared to Newport. That's I think most people will be shocked by that, really, because they assume that Monmouthshire is a wealthy, comfortable place where people are just genuinely happy and have a better standard of life. Clearly, that's not true from these statistics. So, does that correlate with the statistics? These cases that we're seeing in Monmouthshire, are they more complex cases, or is there any evidence? Anything? Are they more rural based? What are they? Because that's what we love data, don't we? We love data.
If I can just make a comment about the data. So the data that I presented today is from the real-time suspected suicide surveillance data set. So those are cases that have not yet gone through that inquest process. So it is likely an overestimate compared to data contained within, for example, the Office for National Statistics data set, which only includes cases that have been confirmed as the cause of death of being suicide. Within the RTSSS, it is still a relatively rare occurrence that somebody does die by suicide. So a small increase of 1 or 2 cases can actually have a big impact when we're looking at rates, when we're looking at percentage changes. And we would expect, just through natural variation, for the rates and the numbers to change, across different local authority areas, across different health board areas, and over time. there's our colleagues in the RTSSS do statistical testing to see, is this a difference that is outside of the boundaries of that normal variation that we would expect to see between different areas and over time. And actually, although the graph with the different local authority areas, basically every local authority area is within that the normal variation, except Blaenau Gwent, actually that's slightly above. And that's something that we're looking at as a public health team very closely in terms of really unpicking what is there anything that we need to be doing over and above everything that Jackie's already laid out. So we are keeping a very close eye on the data from Monmouthshire, but at this stage it is still within that sort of normal variation that we would expect to see.
Okay.
And I suppose the other thing just to note is on that graph it's 3 years worth of data. Because it is still, fortunately, a relatively rare occurrence.
I was just going to speak to that a little bit. So we said this a little bit last time as well, that I suppose what we would see as an acute mental illness is something that where there is a treatment, whereas many people who end their lives by suicide, it might be about debt. So if we see the basic equation of suicide, and I'm sorry if this sounds slightly reductionist, it's where your problems outweigh your resources. And so if your problem is debt rather than depression, then some people might see the drastic solution of ending your life, reducing the burden on your family. And so it is a mindset, but not all of that is amenable to treatment via kind of mental health services. So it's possible that, looking at the mental health, the public health presentation, lots of those factors are being built into the strategy. Debt management, gambling, for instance, being disenfranchised from your family. And we've heard from housing just as we arrived today. And so it's really about spreading the resources through the iceberg rather than putting them all at the top of the iceberg as though everything is a mental illness. Particularly because many people will experience stigma in conceptualising their difficulties as a mental illness. So we don't want to force everybody to the top of the iceberg.
Okay. I mean, I could talk about this for another 5 minutes, but I cannot because we haven't got time. So we've got Steve and then we've got Jill.
Sorry, hi, I was just lost my screen for a minute. Thank you for the really interesting presentation. My question's around those residents that maybe aren't online, that maybe not tech savvy. MCC has got the assistive technology hub, so there is availability of those services for more elderly residents. But what have you got any data on the people that are presenting themselves at risk who might be digitally excluded, and are there ways and means that those people could be educated or provided with devices or whatever they need them, so that they have got access to the kind of resources that we've just seen on the Mello website, for example? And my second question is just around the data. Probably maybe not the time in an election period, but as all of us are outside knocking on doors, we do come across people out there, with various issues, and we just wondered what kind of are the issues that maybe are presenting themselves in Monmouthshire, that whether there's anything that as MCC and as councillors we might need to be aware of, that obviously there's we could talk about rurality as one of the issues, but what other kind of issues, are there any specific trends in Monmouth that we need to be aware of as councillors? So my first question is around the technology, and are we ensuring that residents at risk are access or able to access the technology and the information that is available online? Thanks a lot.
Thank you for that really good question. We acknowledge that the Mello website, although great as it is, it's more for those that are digitally included. So we're trying to do as much as we can to ensure that the information that is available on Mello digitally is also available non-digitally. So every single page on Mello is also printable, downloadable PDF. So we're encouraging all our partners, such as GPs or anybody that has those frontline services that can speak to people, will be able to print off a page from Mello and share that. We also try and signpost people to the Reading Well scheme, which is an excellent scheme. It's a national scheme, which ensures that there's free, really good resources in libraries as well, so we can signpost people to libraries. One of the things we really want to do with the comms engagement and training subgroup is to ensure that the information that is on Mello is also accessible in a non-digital format. So that's a real priority for us. So also conscious that we make sure that our training is available face-to-face as well as online as well. So we are doing what we can and acknowledge that there are people out there that can't access information digitally. So we're trying to, at the moment, just ensure that people have just as well, signpost to the non-digital resources we have, and give frontline staff those resources in a non-digital format so that they can share them as well. Does that answer the first question? Yeah, thank you.
Should I just add to that a little bit? So if you imagine my iceberg again, so inclusion goes all the way through that iceberg, but as you get towards the top, we give disproportionate amounts of attention to making sure that all factors that are covered by the Equalities Act would be in that. And we think about digital inclusion as well. So for our Part 1 psychology service, for instance, we have a device library so that people can borrow iPads, and we have staff that are allocated to help people use that, and they have tech support sessions so that although everything is available in person and online, for those people who, for instance, their anxiety would stop them coming out in person, or who they live in a rural area and public transport doesn't lend itself to that, then they're given tech support so that they can access the same therapy online that they could in person. And we've also teamed up with a third sector organisation so that we've got data banks, so that if somebody is living in poverty and the last thing that they can afford is some data to access online therapy, for instance, then we provide them with the data as well. So as you move up that kind of pyramid of need, up that iceberg, then more attention is paid to some of the factors that otherwise would preclude someone from accessing care.
Steve, are you satisfied? Yeah, excellent. Jill?
Hi, thanks, Chair, and thank you very much for the presentation. You're doing great work, and you can see what improvements you're making. First of all, can you hear me okay? Because I understood it.
Yeah.
Good, great. Thank you very much. Okay, thank you for all the great work you're doing. So I wonder if it's possible to have a diagram of the pyramid or iceberg of support that you're referring to. That'd be wonderful, please. Perhaps in a presentation in the future, maybe, and then we get a better understanding. So also, as you said, it's not just the suicide that's the unfortunate end for some people, unfortunately, but it's all the sadness and involved in the mental health problems that people are suffering with all the time. So the question I've got, please, is what is your view of whether we've got the balance right versus the online courses versus the face-to-face? Is it correct? Are we getting it? Are we doing? We've got more and more online because we haven't got the resources to tackle this pyramid or iceberg or whatever. And what are your views as experts on ChatGPT used by many people? What is the feedback from users? And please do share the Padlet link because I couldn't get that on the Mello. Thank you.
Jill, I remember your questions from last time and they were brilliant, so thank you. Thanks for the feedback. It's really helpful to be reminded to put in a diagram about the iceberg or pyramid. Either will do, either metaphor will do. And so we'll do that in future. That's really helpful. I think we'll probably get into conjecture about have we got the right resources and are they in the right format. I can only speak about more specialist mental health services. And we would be governed by patient choice. And so nearly all of the talking therapies are available digitally and in person. And we give people the choice of how to attend. And we're extending that offer. And we look every month at our attendance rates. And we do our best to call everybody that doesn't attend and ask what would have made it easier for them to attend. So if you like at the top of the iceberg where things are much more impactful, and we define that by the impact on somebody's ability to function in their life, then there is an enormous amount of effort paid to engagement, including in our engagement policies, which aren't, you didn't attend, so you're out. We have a proactive engagement policy that is commensurate with need. So it's really difficult, isn't it, to balance need and resource, but also need is a kind of multifactorial concept, I suppose. So for people that have got rurality, it's hard for them to travel, particularly if they haven't got a car or they've got limited income. So you're balancing all of that all of the time, and I'm not sure any of us have got the perfect answer. I suppose the perfect answer is to co-produce it with communities, so as to be guided by the people that use our services and to engage them, not in evaluating our services, but in co-designing them. And that would be one of the main principles, certainly in mental health and wellbeing, and is a principle that runs through the Health Board strategy. So we will keep, I think your question is really helpful. I haven't got the perfect answer. We'll keep holding it in mind. So thank you for that.
Thank you. Thank you.
Can I just add to that in terms of the service provision? So the suicide bereavement support services that we do have are person-centred. So that service will be offered face-to-face or online. I think from experience, people do welcome that personal face-to-face. Especially the initial introduction, our services go in with like a care pack, tea bags and sugar and biscuits, so they can just have that sort of informal conversation. So that service is offered person-centred, and it's going to be the same with the suicide prevention pilot. It's going to be guided by the users of that service. I think that's really important. In terms of training, we do offer all our training, like the Gwent Connect 5 suicide first aid, either face-to-face or online. What we find, though, typically, and I suppose that is similar to today, people do prefer online. It just seems, and so much easier. You cut down on that travel, you save more time. So we do find that our online courses are filled quicker, and we end up having to put more online courses on than the face-to-face. And we do reflect on that, because I think people get a lot more out of those face-to-face discussions and the face-to-face training. So we do try to encourage people, particularly those frontline staff, to come in and do the training in person rather than online. But yeah, no, I take your point. But yeah, since COVID, I think there's been a real move towards more online training.
Thank you for that. Please, Chair.
Sorry?
Can I just come back, please, Chair?
No, I'm really sorry because
just
we're running.
1 second.
No, honestly, I'm really sorry because Steve's next. So I do apologise.
Online is not, face-to-face online.
Okay, Jill, you can come back at the end if we've got time. Steve, Miriam, I do apologise. No, Steve's been. He's been.
Apologies, sorry. Thanks very much all for the presentation. In the earlier report, we heard that the community mental health team duty desk had undergone unanswered calls and unreturned, along with risk-related sort of emails that weren't replied to. Is the extra 2 community mental nurses that are now employed helping to address this issue? And also on your point on the graph on slide 9, I think it was, about the Monmouthshire being at the top of the, or close to the top anyway. And we noticed that Newport was quite low down there. Are we identifying anything in with Newport as a local authority that are doing something different to what we're doing? And are they, operating on a better practice in any way? And then just finally, if we've got 46 elected members here, what can we do? Maybe suggestions, 2 or 3 easy suggestions that you've done the suicide training, and I've taken part in that, and I've really felt that helpful. But coming out of today, what can we go out in our communities and share? So,
well done, Miriam.
It's remembering all the questions, isn't it? There's 3 questions here. Okay, the first one, obviously more staff will always help, but my understanding, and I think Megan's confirmed this a little bit, is it was an operational issue with the phone number, and that's been corrected. So I think that helps, although inevitably more staff will always help. So yeah, I suppose that's the first one, is hopefully that operational issue has been ironed out, and this move towards 111 Press 2, which I would encourage everybody to utilise. It's a really helpful service, very well trained staff, registrant practitioners in the background supporting clinical decision making, is to use the professionals line if needed, because I guess that gives instant access 24/7. So hopefully all of those operational issues have been ironed out. Your middle question about Newport, public health colleagues might know more. I think the term that's always used when we try and compare health boards, for instance, is you're comparing apples and pears. So for everything that we looked at in Newport, where you will have some kind of social drift, won't you, towards a city, you'll have more diversity, more of an asylum seeking and refugee population, that also will attract different resources. So they will have other challenges, and my understanding is their commissioned projects will reflect their population. So it's really difficult to compare. When we were here last time, we talked about some of the projects that are partnerships between Health Board and local authorities, particularly around housing, homelessness. We're thinking more about some of the kind of public health targets. So addressing the more social factors of emotional and mental well-being rather than mental illness, that model, if you like. And from my perspective, your third question, I guess we're all citizens. I'm a citizen. I'm also a well-trained citizen in terms of mental health and well-being. So there's something around everybody having a degree of emotional literacy, and being an open recipient when somebody is distressed and needs help, of encouraging people when they're having suicidal thoughts. I suppose the strapline is please wait. It passes. We know the theoretical model of suicide is around a bubble, where your thinking has become very focused on one solution, which is dying, and it just takes a stranger or somebody who's kind to burst that bubble, and once someone's out of that bubble, they can often think more clearly again. So lots of the public health campaigns, telephone numbers on railway bridges and those sorts of things, are around bursting that bubble and being around. So be a kind stranger. I think we can all do that. And in big organisations, lots of the evidence is around people in very senior positions or respected members of communities being open around their own emotional struggles, and that allows some of the stigma to be broken down. So from a clinician and a kind of citizen in our communities, I guess that's what I'd say. It's about how we all conduct ourselves, and holding other people's distress with kindness, letting them know that there is help available.
Thank you. Are you happy with that, Marianne? Yeah.
Yeah.
Well, I'm sorry. I'm not going to let you do that, only because you're running out of time. Yeah. I'm going to be really strict and say no. So I do apologise. So but I do have Megan. She was so fantastic before. I would genuinely drive away on the home if I hadn't allowed her to speak now and have a final question. She's got her hand up twice, in fact. I would feel really bad. So I'm going to let Megan, take it away for us as a finale question.
Sorry, it's literally a really quick question. It's just the professionals call for 111 is amazing, because we've got that so many times where we think we really need to tell you something and we can't. Is there a scope of being able, we used to be able to refer somebody into community mental health directly, because we've been working with the client for so long, we've got more of the background, and I'm aware that when doctors refer into mental health teams, at times they can literally be one sentence long and can literally be something like, this person wants to harm themselves, can you help? We were able to give so much more background. Is there scope to be able to allow like third sector agencies to be able to refer into yourselves or contribute to the referral scheme at all?
Yeah, so I think the teams will receive referrals from anyone. I think particularly as we move to this open access model and a single point of referral. Can I come back to you on that, Megan? Because it might be around the interface, and it sounds like that interface is improving. So can I come back to you on it, because I'm wondering if there's some variance.
Yeah,
but it's such a helpful question. So if I can get your email address, then I can answer that more directly. Is that okay?
Yeah, that's no problem.
Thank you.
Right, I'm under tremendous pressure here to let people speak. I'm being heavily lobbied, and you've done an excellent job, but the answer's no. I'm going to summarise, really, because it's important that we let you go. I don't believe there are any other questions. I think everybody's had a good opportunity to indicate that they are. I'm going to summarise, really. So effectively, I think what we do need is certainly more suicide training. We're going to do a press release, I think probably a joint press release in relation to this specific meeting and some of the details we've covered, and then also to then help you promote the leaflets that you've produced, which is fine, and then and we're going to become Mallow champions as a council. Fantastic, that's great. And as far as further scrutiny is concerned, obviously you guys are welcome to come back. I'm sure you can't wait to come back till next time to then speak to us. But we're also then going to invite Mental Health and Learning Disability Board to a future meeting. And I think that's probably necessary. So you're one strand of it, they're another strand. I'm going to say thank you very much again for coming along. It's been an excellent session. Again, thank you, Megan, for coming along. Thank you, guys, for coming along. This is something we're going to come back to. We've got 1 year left of this term of office, and I'm determined that we're going to try and make the most of it. So thank you all for your cooperation, and I wish you a good day. Thank you.
Thank you.
Thank you.
Right, moving.
Jackie, have you got the leaflets?
Yes, I've got the leaflets.
Thank you. I'll put them in the pigeonholes.
Okay.
Okay.
And I would love to speak to you about being mayor champions.
Okay, so I'm still in the meeting now. Okay.
Yes, as long as she's happy with that.
Yeah, if you could check.
Yeah. Okay.
So that it doesn't drift. Thank you.
Right. Okay. Thank you, guys. So 5.1. Number 5 on the agenda. So the received minutes of the meeting, which is if you look at the pack, it's the agenda item 5A. Yeah. And then should we take them both together? And then 5.2. Are members satisfied with that's a fair reflection of the meeting?
Yes. Yeah.
Yeah. Yeah. Is that a nod? I need a vocal just in case for everybody's. I can't just have a thumbs up out for those of people who are visually impaired. I need a second yes online. Yes. Yeah. Fantastic. So that's great. Number 6 on the agenda is the Public Service Scrutiny Committee's forward working plan, which is Hazel once she's finished chatting to our guests. Thank you, guys. Thank you. Yeah, Hazel. 6.
Yeah, so just to inform members that we did have a meeting next week on the 28th, and unfortunately we've had to rearrange that because it was to invite the Chief Constable of Gwent Police to discuss community safety and police resources, outstanding questions from previous scrutiny back in December. So we're going to rearrange that meeting after the election, and I'll be in touch with you in due course about a date for that. So the next diarised meeting after that will be the one on the 8th of June, which is an update from Johnny Hill from National Highways. You're very familiar with Johnny now. We tend to do one item per meeting because, as you can see with today, it allows you to go into it in greater depth. So that's all to say at the moment, Chair.
No, that's great. And just to say that our relationship with National Highways is improved. Johnny now phones me on occasion when I'm driving home in the car. Obviously, when I'm on an English highway only, I don't know if he knows that. Maybe they've got cameras watching me do it. I would say there's a more informal dialogue. So that's helpful. So thank you for that, Johnny. Moving on. Is there any other further comments I need? I don't know. That's it, really. So we've got the Council and Cabinet Work Planner on 3334. Hazel. Sorry? No, I'm asking.
It's just for noting.
Oh, just for noting. Yeah. Are there any other questions? Yes, Jill.
Just wonder if the Public Services Ombudsman report would be something we might be interested in because it's public services.
Yeah.
And also the strategic risk assessment, I know normally goes to P&O, but could we look at that versus public services, the risks versus public services that we might want to look at? Would that
well, certainly the Ombudsman, I think, is an excellent suggestion. The latter one, what do you think, Hazel?
It is more P&O, but
It's
maybe
probably
when we
be-
look at it, we could invite your committee.
How about, yes, did you catch that? So they could look at it, they could invite us to the committee meeting, and we could be guests to theirs. How about that? Or if they don't want to do that, we could look at it and then we'd invite them anyway. What do you think? I'm joking, obviously, but we'll get to the bottom. I think that's an excellent suggestion. And then finally, the next meeting is on the 8th of June, so that's at 10 a.m. Is everybody happy with that? Are there any kind of complications? Anybody got any kind of something that they, or you guys are my regulars, with the exception of Dale as well. He's away working on his chateau in France. Is everybody happy with that day? It's morning. It's always morning, isn't it? 10 a.m. So Penny's going to, we're aiming to be by 1. Thank you, guys. Alistair, thank you for coming along today at short notice. I really appreciate it, and particularly the questions you've been putting in are excellent. So we will send you a special public services badge you get to wear around for a while. But thank you, and we'll hopefully see you again in the future. That concludes the meeting for today. I'd like to thank all the members for their cooperation. Is this technically the end of the year as far as the... Yes. Yeah. So I'd like to thank all of you sincerely for your input. You're already going, some of you, I think, actually, before I even thanked you. It's been really interesting, some of the questions we've put forward, some of the debates we've had. I particularly thank you for your patience with my direction of travel on the, forgive the pun, on the Severn Bridge. It's something that's kind of close to my heart, but I'd like to thank you all for your cooperation and your patience with me over the year. Hopefully I'll see you again next year, and I'd like to wish you a good day. Get outside because it's a lovely day. Bye, everybody.
Thank you, Chair.
Thank you.
Thank you. Bye.